Good evening, everybody. On behalf of ISHA, I welcome you all to the fourth webinar of this year, titled Management of Tinnitus by Dr. P. Manjula. Before we start the webinar, there are a couple of things that I want to convey to everybody. After the webinar is completed, if anybody wants to ask any questions, there are two ways. One, on your panel on the right side, you can see a hand raising symbol. You can either click on that, and then when your turn comes, your mic will be unmuted and you can ask the question directly to the presenter. Or the second option is that you can see a question mark on your panel. You can click on that and type the question and send it. The question will be answered. Now, I welcome President ISHA, Professor Asha Yathiraj, to please introduce the guest and start the webinar.
Thank you, Achaiah. Welcome all the participants to this fourth webinar of ISHA on Management of Tinnitus by Professor P. Manjula. This is the fourth among the 9 different webinars that we will be conducting over the year. And this one has had so far the record number of participants. We have 41 participants who have registered for this program. As of now, only 26 have logged in. Hopefully, the rest will log in over a period of time. We are trying very hard to get RCI points, and I'm sure with our effort that we're putting in, that we would be getting the RCI points, CRE points for this set of webinars. So those who have attended 3 or more are likely to be, will be getting the RCI CRE points. So to tell you about Professor P. Manjula, her name is synonymous with Management of Tinnitus. She is an alumnus of the All India Institute of Speech and Hearing and has done her bachelor's, master's and PhD at the All India Institute of Speech and Hearing. She has close to 30 years of experience at the institute and has published approximately 100 articles in national and international journals. She has some very special training in the area of tinnitus. This is specific to tinnitus retraining therapy, where she has been trained by the master of this technique. Professor Manjula has been a very dedicated staff of there. I'm proud to say she is my doctoral student and has done an immense amount of work on tinnitus at the Institute. I welcome you, Dr. Manjula. Please take over. Oh, well, for 1 minute, before you take, I'm sorry, Manjula, one more message to all the participants before she takes over. I would like all the participants to know that the software that we have is very sensitive and it can tell us whether a person is attending or not attending the webinar. You may have logged in, but the software is also logging in a symbol to the organizers, indicating whether you are actually attending the webinar or not. So I really hope all of you are sincerely attending it, because we can make out if you're not attending it. Thank you, and I expect all of you to be actively attentive and participating in the end of the webinar. I welcome Dr. P. Manjula once again to start on your presentation.
Thank you, madam. Good. That was an exaggeration. I know very little about tinnitus, and it's always a pleasure to share whatever little I know. Good evening, everyone. I wish to thank ISHA for inviting me to talk on this topic. Tinnitus being such a common condition, I'm sure many of you among the participants are successfully managing clients with tinnitus. And so here is a chance for us to interact and learn from each other. So on this topic, today's learning objectives will include to recollect the tinnitus, what we know about tinnitus and the characteristics of tinnitus, and also the management of tinnitus in general. And I would also like to refresh upon the one particular mechanism or model of tinnitus in very brief because of the time limits. And then the role of counseling in the management of tinnitus, habituation in the management of tinnitus, and how to monitor progress in the management of tinnitus. So I'm expecting to achieve these objectives by covering these topics in my talk: tinnitus characterization, management, model of tinnitus mechanism, and counseling and habituation in the management of tinnitus. So let's start with the first topic, that is tinnitus and its characterization. Okay, as all of us know, tinnitus is a symptom and not a disease by itself. It is a perception of sound, and it is not related to any external sound without corresponding mechanical vibratory activity within the cochlea. And this is a result from the activity within the nervous system. And all of us at some point in life have experienced tinnitus. In the general population, there are about 10 to 20% of population who experience tinnitus. Among those who experience tinnitus, 25% of them really suffer from disabling tinnitus. So we have quite a number of them who suffer from tinnitus. So actually there can be two types of individuals having tinnitus. One, those who just experience tinnitus, but they are not distressed by it. The other is those who experience tinnitus and also suffer by it. Those who are severe, those in whom the severity is more and hence they suffer. So there are actually two categories of tinnitus: individuals with tinnitus, those who experience tinnitus, and those who suffer from tinnitus. And among those who have tinnitus, there are about 25% of those individuals having tinnitus who also have hyperacusis. Okay, now coming back to the characterization of tinnitus, or knowing the characteristics of tinnitus, we usually describe tinnitus in terms of its pitch, whether it's a high pitch or a low pitch tinnitus, or whether it's a broadband signal or it's a tonal signal, and things like that. So the tinnitus will usually have the pitch, and it will also have certain amount of loudness. This loudness, okay, surprisingly, the loudness of tinnitus never exceeds 10 or 20 decibels in all those who have tinnitus. That is, those who suffer tinnitus and those who experience tinnitus, the loudness of tinnitus is very rarely more than 20 decibels. Reference is the threshold at that particular frequency or the particular signal at which they have identified the pitch of tinnitus. And there is also a phenomenon which is attached to tinnitus, something called residual inhibition, where when we give a white noise for a duration of about 1 minute, the person who's here having tinnitus can, after the cessation of the signal or the white noise, the person can show some amount of residual inhibition, in the sense the person may experience reduced tinnitus or no tinnitus at all, or it can be even no change in their tinnitus. Okay, and these are some of the psychoacoustic characteristics of tinnitus. But these psychoacoustic characteristics of tinnitus are same in individuals who experience tinnitus and those individuals who suffer from tinnitus. Okay, the pitch is almost the same in these two groups of individuals. The loudness is the same. Residual inhibition in terms of masking curves or maskability. Okay, actually we can't use the term nowadays. The trend is not using the term maskability. It's the suppression. Suppression of tinnitus is what is being used these days. All these parameters of psychoacoustics are similar in individuals who experience tinnitus and who suffer from tinnitus. Okay, so thus we have another way of characterizing these two groups of individuals where subjective characterization comes into role. And this is done by using the questionnaires or inventories that are developed for the purpose of evaluating the severity of questionnaire. The subjective characterization is the one which will differentiate between the individuals who experience tinnitus and the individuals who suffer from tinnitus. The questions that are there in these questionnaires, such as tinnitus handicap inventory or tinnitus functional inventory, will be something like estimate the percentage of waking hours that you have tinnitus or that you are aware of tinnitus. So one person who is experiencing the tinnitus may say that he is experiencing it for about 70% of the time. Okay, and now another question that could be there in these questionnaires would be estimate the percentage of waking hours that you are annoyed from tinnitus. Okay, so for this question, actually, the answer that is given by the experiencers and the sufferers differs. So one may say I'm annoyed maybe 20% of the time in a day, or the other person may say I'm annoyed for 80% of time in a day. So this is what differentiates the person who just experiences, and the person who suffers from tinnitus. We have to differentiate these two groups of individuals because the management, we mainly focus on those individuals who suffer from tinnitus. So as I said, pitch, loudness or residual emissions, these psychoacoustic characterization of tinnitus, it has been found in literature that there is no correlation between these psychoacoustic characteristics such as pitch, loudness, residual inhibition, maskability and all. There is no correlation between these psychoacoustic characteristics and the severity of tinnitus. As I said, there is a better correlation between the subjective measures and the severity of tinnitus. Okay, and also the outcome from therapy. Okay, when we measure the outcome from therapy, there is a better correlation between the subjective measures rather than the psychoacoustic measures. So when we say subjective measures are better than the psychoacoustic measure, is it important that we measure the pitch, loudness of tinnitus? Is it necessary for us to characterize the psychoacoustic parameters? Okay, this is a question one may ask, but it is important to do psychoacoustic characterization also. That is because just to reassure the patient, saying that yes, you have tinnitus. See that we can measure, the very fact that we can measure tinnitus says that you have a problem, something called tinnitus, and then it's nothing like you're possessed by a devil or something like that. Okay, so it's a measurable condition, and there is nothing much that you have to worry about. So this, as I already said, subjective characterization shows better correlation with the severity of tinnitus and the treatment outcomes. So by using those questionnaires, we can measure how the therapy management is progressing. Okay, therapy or management is progressing. We can monitor the outcome of therapy based on these subjective measures. Okay, because psychoacoustic characteristics are similar in people having who are experiencing tinnitus and those who are suffering from tinnitus, we can infer that auditory system is not very crucial in the mechanism of tinnitus. Systems other than the auditory system are responsible for tinnitus. Okay, coming to the next topic in the under the topic of management of tinnitus, we have management of tinnitus in general. Okay, so there are in the literature, and we've seen that there are various forms of treatment or management approaches for tinnitus. These include dietary restrictions, something like you may have reduced intake of caffeine or increased intake of vitamins and minerals. But however, there is no clear-cut linkage between the diet and the tinnitus. Okay, and there are various medications that are also prescribed for tinnitus, such as antidepressants, anti-anxiety drugs, and all these, some of these, and some of them may even have side effects, such as they may reduce the plasticity of the brain, which is very much important for habituation of tinnitus. Okay, and it is also like when they withdraw the medicine, there can be re-emergence of tinnitus, or there can be addiction to the medicine. So there are certain side effects of having medicines, and there are certain very important aspects which are also, I mean, potential treatment with medicines for tinnitus. And in terms of surgery, it has been found that it has been found that any surgery that will improve the condition of hearing will also reduce the perception of tinnitus. That is because we will be able to hear the background signals, those signals that we are actually not hearing before the surgery or medications. Okay, so that way surgery is going to help. And there are also some of these cases who've been implanted with cochlear implants. Okay, those having severe to profound hearing loss and implanted with cochlear implants have also reported of reduced tinnitus. And in some cases, the tinnitus is enhanced with electrical stimulation. But we need more evidence, scientific evidence, to conclude whether surgery is going to be beneficial or not. So, and the other form of therapy that is usually found in literature and we come across as, psychological aspects, which will include cognitive behavior therapy and all. So in that, the relaxation and breathing exercises are all put to use. All these also can be very useful. Cognitive behavioral therapies can also be very useful in reducing the tension, in improving the quality of life, and also improving sleep, which is very much affected in these individuals suffering from tinnitus. And there is also, report of using music therapy, notched music therapy, and all. In addition to the other advantages that these kind of therapies have, they provide relaxation. Thus, it will help in better management of tinnitus. There are other forms of alternative therapies which include acupuncture, homeopathy, and all, where greater evidence is required to conclude any thing. Okay. Now, next is, as audiologists, we've always tried masking for tinnitus. As I said earlier, masking and the actual masking that we use, the term masking that we use in audiology is slightly different from tinnitus masking. That is because in audiology, the term masking, am I fast? I don't know whether, okay, I'll continue with this rate only.
Manjula, it is fine. Can continue. There's no problem.
Okay. So with tinnitus masking, okay, because here something like you have tinnitus in the regular masking that we use in audiology, in the field of audiology, we mask the ear which has got the crossover tone, okay, and then we will be masking that particular tone in the non-test ear or something similar to that. Whereas in tinnitus, even though the tinnitus is there in one particular ear, we use noise in both the ears. And in the audiology, in the field of audiology, okay, we have the tinnitus. I mean, if you are masking a particular signal, for example, a 1 kilohertz signal, we use a narrowband noise to mask that. Okay, so a critical band for masking is effective there, whereas here with tinnitus, okay, a broadband signal is more effective than the narrowband signals, because broadband signals are known to stimulate more number of neurons, and thus being more effective for tinnitus management. Okay, and then earlier the total masking of tinnitus was in vogue, in the sense we have to cover the tinnitus by the external sound totally, that is to a level such that the actual tinnitus is not heard. Okay, but now once this is done, the actual tinnitus is not heard, and then we will not, and as the masker noise is removed, actually there can be a re-emergence of tinnitus after some time. Okay, so they have thought of the tinnitus suppression or partial masking, where actually the level of noise is not that much to cover the total tinnitus. It is just below the level of the tinnitus, such that the noise is also heard and tinnitus is also heard at the same time. Okay. Now we've also heard of using hearing aids in persons having hearing loss and tinnitus. Okay, so these hearing aids are devices that will amplify all the sounds in the environment. So thus, they act to reduce the contrast between the tinnitus and the background stimulus, which will promote the habituation to tinnitus. Okay, so that means to say that, like until the time that he was not wearing a hearing aid, okay, the person was not able to hear all the small background noises that were there in the environment. But now with the use of hearing aids, these sounds also get amplified, and through the hearing aids, okay, so, and then the level of these background noises should be adjusted in such a way that the level doesn't completely mask the tinnitus. Okay, and when a hearing aid is prescribed to such a case, it should always be binaural if there is binaural hearing loss, bilateral hearing loss, and it should be an open ear mold or a vented ear mold that should be used. And noise reduction strategies, because noise is the one that we are looking for to promote habituation. Noise reduction strategy, use of noise reduction strategies is again a question mark in such cases. There are various devices and tools with variations that are available now commercially. Those include just the sound generators, which will generate only the signals of different frequencies, different pitches, bandwidths, and white noise and all that. Those are sound generators. And we also have combination instruments where the sound generators are combined with the hearing aids, and there are various mobile apps that are available which can be downloaded and can be used for the purpose of generating the noise. Okay, now coming to the next topic, that is on the mechanism or model of tinnitus. Okay, so as a general background, all of us are bombarded with many sounds in the environment. And each of these new sound in the environment will have to be evaluated and classified as whether it is a relevant signal or a non-relevant signal, whether it's significant to us or whether it is important to us or whether it is not important to us, before the unimportant ones are ignored. Okay, so example, some of these sounds that we hear every day. For example, a mother who's sleeping in the night, okay, doesn't respond to the loud thunder noise that we hear during the rainy season. But however, she's awakened by the soft baby cry that is there during the night. Okay, so this is the amount of significance that she pays to the baby cry rather than to that of thunder. And there is another kind of noise that there is another noise which is the refrigerator noise. Okay, so these are just examples I'm going to give you, because these examples will help us when we go into the actual mechanism of tinnitus. This refrigerator noise, initially when the refrigerator is installed newly at home, okay, we feel that the noise from the refrigerator is high and it will always be drawing our attention. Okay, and then after 2 or 3 days, we don't even pay attention to that noise, because we would have considered that refrigerator noise to be not relevant or not significant or not important. So though there is noise, the refrigerator noise, we don't even hear that. We don't even perceive that. We hear that if we pay close attention, but we don't perceive it. So that is what we should do for tinnitus. Okay, now coming to the neurophysiological model. Okay, so this is a brief block diagram of the neurophysiological model that was put forth by Jastreboff. Okay, so now with this model, okay, when we hear a new sound, when there is a new sound to the ear, okay, the cochlea responds to it. Cochlea hears that and it passes that on to the subcortical and cortical structures, where the signals are detected and evaluated at the cortical structures. So if the signal is a signal that we have already If the signal is a signal that we have that we associate some mild, for example, if this new signal is something like a tinnitus, okay, so if that signal is I mean, if we associate that signal with some kind of negative association, something like fear, okay, so that fear is the function of the limbic system. Okay, emotional associations are controlled by the limbic system. So when we associate that particular sound with fear, okay, so now this sound will be now associated with increased heart rate or increased BP or breathing or sleeping disturbances and all that. So now when there is a sound, a new sound, if it is neutral, then it just detected and it will not go further to the higher cortical centers after the initial evaluation. But if this new sound is something that causes fear, then it will associate itself with the limbic system, it will associate itself with the autonomic nervous system, and there will be certain emotional and other parasympathetic responses of the autonomic nervous system. So when there is a new sound, it has to be categorized as either important or neutral, and or is it associated with negative negative associations such as fear, anxiety, and things like that. So if it is important, if the new sound is important and we have to respond to it, the cortex will send immediate message to the concerned parts of the body to act on it. And if the signal is neutral, something like a refrigerator sound, then all the other connections are not there, so we do not perceive that sound at all. It's just heard sometimes when we are focused to it, but it is not heard. So that is what happens to a neutral signal. And when we have negative associations attached to it, such as anxieties and all, then there will be a loop that is developed, the subcortical loop and the cortical loop, which will become stronger and stronger when there is continuous tinnitus. So this kind of associations that develop form a conditioned reflex, and this is what we need to break in the management of tinnitus. Okay, so in the management of tinnitus, what we plan to do is that if there is a sound, okay, we have to classify that, or we have to counsel that particular client in such a way that that particular tinnitus sound, which is associated with anxiety, turns to be a neutral sound. I'll explain that later how we can do that. Okay, so with this neutral sound, and there is a neutral sound, okay, so there will be no information from the cortex to the limbic system to the autonomic nervous system. All these reactions will be will be controlled when there is a neutral signal, and hence there will be no reaction. That is, the heart rate will not increase or the BP will not increase, and there is no such reactions. All these are deleted. Okay, and then this will help when there is no reaction. Okay, in the limbic system also the emotional responses will be reduced or even absent. Okay, and thus this the cortical feedback loop and the subcortical feedback loop will not come into role when there is a neutral stimulus. So here we can say in this simpler diagram, when there is a tinnitus, okay, when we treat it as not important, as in case of a refrigerator noise, okay, we don't perceive that signal. Okay, we do not perceive that signal, and this is what happens in those individuals who experience tinnitus. So in those individuals who just experience tinnitus, though they have tinnitus, they do not pay attention, they're not very anxious, they're not fearful about tinnitus, so that will not form a conditioned reflex loop there, and it is not perceived. But those who are suffering from tinnitus, okay, so the tinnitus will be associated with fear. Okay, they fear, saying that because I have tinnitus, this can lead to something like a tumor in my brain, or a tumor in the auditory system, or it may lead to deafness. These are the fears that some of them may have. So these are called negative associations, and when this negative association increases, the stress, anxiety, the other autonomic nervous system reactions will also increase, and this becomes a vicious circle, and this is what happens in a person suffering from tinnitus. Now, as I said earlier, those who just experience tinnitus without suffering from it may not require treatment or may just require some amount of counseling, whereas those who are suffering from tinnitus require treatment or management approaches. Now, the goal of management of tinnitus is for us to make these sufferers become just experiences or non-sufferers. So this is the main goal of management of tinnitus, which I'll be focusing today. So with management of tinnitus, counseling plays a very important role. Okay. So as in tinnitus retraining therapy, that is TRT proposed by Jastreboff, okay, the counseling and rehabilitation are the two important aspects in the management of therapy, in the management of tinnitus. Counseling, the aim of counseling in the management of tinnitus would be reversal or retraining of the feedback loops that are formed between the auditory, limbic, and the autonomic nervous systems. And now, how do we explain all this to our patients during counseling? It's very difficult to make them know about these different nervous systems and all. Since it's difficult to explain all these, we need to have some stories or some parables to explain these concepts to them. So during the counseling sessions, we have to demystify tinnitus. That is, we have to reclassify the tinnitus as a neutral sound. They would have thought that tinnitus is a dangerous signal which is going to harm them and all, and now we'll have to classify that tinnitus as a neutral signal during counseling. We have to remove the negative thoughts that are associated with tinnitus. We have to remove the fear or anxiety that is associated with tinnitus. And also, we have to remove the belief that there is a serious threat. Okay, it's not that tinnitus is going to cause a tumor. It could be that a tumor condition is associated with tinnitus in rare conditions. However, tinnitus is not responsible to cause either a tumor or a hearing loss, so it's not a serious threat. We need to tell them about this. Okay, and also we have to remove the notion that nothing can be done about it. So that is what some of when they come to some of the management specialists, okay, we tell them that nothing can be done, or you have to learn to live with it, or just ignore tinnitus. Okay, all these are not to be said. We should never say that nothing can be done with tinnitus. You have to learn to live with it or ignore it. So with that, okay, we have to reclassify the tinnitus into a category of tinnitus which are neutral signals. Okay, so the stories that I was telling you, okay, so one or two examples I've taken here. Okay, supposing I've gone on a holiday, and then after a good days of sightseeing, I go to a hotel or a resort and take a room there, and then I'm going to use that room to stay overnight. So during the night, okay, suddenly I start hearing some hissing sound. So this hissing sound, okay, because of this hissing sound, I do not get sleep at all that night. Okay, thinking that this hissing sound could be that of a snake, okay, and then there could be a snake nearby or within the room or maybe just outside the room. So thinking of that, I never get a sleep overnight. But if on the next day when I complain that to the reception or the front desk manager, okay, if he says that hissing was not because of a snake in the nearby vicinity, but that was because of the air leakage in the neighboring petrol bunk or something like that, okay, so the next day I get a good sleep. Okay, so this is what we need to tell the patients having tinnitus. Okay, patients suffering from tinnitus, we'll have to tell them tinnitus is a harmless condition. There is no threat from it, and That is what we need to convey to them. Okay, we have to reclassify that. And supposing there is another example given here. Okay, so we can see here a tiger inside a room, and this tiger inside the room, supposing I'm lecturing the students, and then there is a tiger in the room like this in the corner of the room. So whatever I tell my students, the students will not be understanding anything. They will be thinking of this tiger, even though I've told them that this tiger is a tame tiger. It has not done any harm to any of the individuals earlier, and any amount of this kind of advice, okay, will never go into their head. They're always having that fear in the corner of their mind, okay, which will not allow them to listen to the lecture. Tinnitus is something like that. Okay, it is always there in our head. It doesn't allow us to concentrate upon any other activity in life. Okay, we are always thinking of tinnitus. So when we tell them that tinnitus is harmless, it doesn't cause any kind of pathology and things like that, we have to classify them. That's a particular thing, the tinnitus, as the signal which is a neutral signal, something similar to that of a refrigerator noise. So we can also tell them that tinnitus is always associated with a condition, okay, such as something like Meniere's disease, which is a condition. Okay, and then Meniere's disease gets the tinnitus due to Meniere's disease can get ameliorated with some amount of medicines which aim to treat the condition itself. So tinnitus is not a cause of that Meniere's disease, but tinnitus is associated with it. Okay, so with that, we'll have to reclassify the tinnitus, saying that it is a harmless condition that is existing. So now the next topic under the management will include the role of habituation in the management of tinnitus. Okay. So once we counsel the clients saying that it's a neutral signal and it's not fearful and things like that, that will reduce most of, at least 50% of the audience. So in my clinical experience, I've seen that after a session of counseling, a lot of fear, anxiety and all is reduced. At least 50 to 60% of anxiety and fear is reduced, and they are able to go satisfactorily before the next treatment on sound therapy starts. So this habituation in the management of tinnitus, okay, each of these signal, there are many signals in the environment, and each signal which is presented to the central or nervous system is detected based on the contrast that is there between the signal and the background. So when I'm talking, if I'm there in a room which is very noisy, my speech will not be heard. Whereas if I'm talking in a quiet room, my speech will be heard clearly. So in this example, for example, in this picture, okay, we have a candle. We have candles which are burning here, and then this light is brighter because of this dark background. That is, the contrast between the background and the signal is more. That's why we are able to perceive the brightness of the candle. Whereas here in this context, the background is a daylight, for example, and there is a candle which is burning in the daylight. So the contrast between the daylight and the candle light is not much, and we are not able to perceive this. And we are not able to perceive the brightness of the candle in the bright day light. Okay, so this is what happens to the tinnitus. When the tinnitus is there in a quiet environment, most of our patients will also complain about this, saying that the tinnitus is loud when they are in a quiet environment. The tinnitus is loud when they're about to go to sleep. So this is what is the usual complaint of many of these clients suffering from tinnitus. So that is what is happening. The background is soft or quiet, and the tinnitus is loud. That's the reason they're perceiving it, or they're disturbed too much by that condition. Whereas in this kind of condition where there is tinnitus and there is background noise there, sound enrichment in the environment, then the strength or the loudness of tinnitus is not much, and they're not disturbed by the tinnitus. So this has to be followed in the management of tinnitus. Okay, so when we see this figure here, okay, there is a tinnitus here, tinnitus signal with some amount of background noise. Okay, but when the background noise is very low, the tinnitus is loud. When the background noise is high, the difference between the background noise and the tinnitus is not much, and then we do not pay much attention to tinnitus. So tinnitus is, there are chances that the tinnitus is not perceived that well. Okay, so in the habituation that is there in the TRT, this is what is advised, that this is what we advise the clients. Okay, so we have to reduce the contrast by avoiding being in silence. That is, we have to use sound enrichment. Okay, how do we do that? Okay, so sound enrichment is done by exposing the individuals to the to different kinds of sounds in the environment. It can be done by exposing the individuals to white noise, or it could be some other kind of environmental noises that are there in the environment. Okay, but these noises should be neutral. It shouldn't evoke any emotional responses. Okay, it shouldn't be annoying. It should be neutral. Okay, and you should have a stable source. That is this the noise that you're going to expose the client. Okay, it should have a stable amplitude and spectrum. It shouldn't be too much varying. It should be stable. It should not be annoying. It should be exposed to binaural ears. Okay, and it should minimally interfere the perception of the environmental sounds such as speech and other environmental sounds. Okay, so to promote that, we have to use open ear modes along with some of these sound generators that are available commercially. So we have to have a stimulus which is of wide frequency range, because it stimulates many neurons. If it is a narrow band or a pure tonal signal which is used for the sound enrichment, okay, it stimulates a limited group of nerve fibers, so the habituation gets delayed. Okay, and for sound enrichment, it's preferable that music, it is preferable that music is not used. That is because it draws the attention towards listening to music, and then that indirectly draws the attention to having tinnitus, which is against the rule for habituation. Okay, and then when we are exposing the sound to the ears, okay, we should always set the level of the signal at the level of the mixing point. What I mean by mixing point is that is illustrated in this figure. Okay, so supposing this in this figure, the horizontal axis is the sound intensity level. As I go from left to right, okay, the sound intensity increases, and on the y-axis, the effectiveness of habituation is measured. Okay, so as we increase the level of the background signal during sound enrichment, if we increase the level of the background signal, the amount of habituation that is taking place is increasing. Okay, and as I go on increasing the level of this signal to a higher level, there is a point where the person is hearing the tinnitus. Okay, at all these intensities, the person is hearing the tinnitus as well as the external noise. At a particular intensity, the tinnitus just blends with this external noise that we're giving. So this is called the mixing point. So when we increase the level of tinnitus, increase the level of the sound enrichment, okay, at a particular point, the level of tinnitus and the level of the background enrichment, sound enrichment mixes, blends. That means to say the tinnitus starts to change in terms of its pitch or quality. So this is where we call it a mixing point. So the sound during the sound enrichment, the loudness of the background signal has to be just below this point, okay, in these levels, or just at that level, or just in this range. If the level of the sound enrichment is set at, then there will be maximum benefit or maximum habituation that will happen. Now, we should remember that counseling or habituation, when we do this kind of a counseling or when we perform sound enrichment with the purpose of habituation and all that, okay, it doesn't cure tinnitus. That is very important. We should tell the patient in the beginning itself that our management will not, management of tinnitus, the procedure that we use, because it does not remove tinnitus. Okay, but what we try to do is we will make it neutral. That is a signal which is not significant, which is not important. That is what we do due to habituation of reactions which are mediated by ANS system, autonomic nervous system, and the habituation of perception of tinnitus is done through this counseling and the process of habituation. Okay, so this is, we should make the patient understand this fact that the tinnitus may still be there, but I'm not disturbed by it. I'm not distressed by it. The tinnitus is not disabling. This is what we should convey to the client. When this is done, when the habituation process is done, okay, this will make the patient to cope, even when he has a tinnitus, cope well with the activities in the daily life. Okay, he participates well in the daily activities and will also lead a normal life with good sleep, good health. Okay, and then as I said in one of the earlier slides, okay, tinnitus most of the times is associated with hyperacusis, and when it is associated with hyperacusis must be treated first with something like progressive desensitization and enriched sound environment and things like that. And for hyperacusis, we should always discourage the use of ear protective device. This is very, very important. Okay, and then the last aspect of the management of tinnitus is monitoring the progress, which is very, very important. We have to know whether the aspects that we are following for management is bringing about any progress, or whether it's helping them or whether it's not helping them. We need to know about this. So we have to monitor the progress. And the habituation usually takes time. So improvement, a slight amount of improvement is evident in the first 1 or 2 months when we use this sound enrichment and all in most of them. And however, okay, it's not necessary that the patient will have to come to us always. Okay, initial 4 or 5 sessions he may have to come just for him to understand what level he used to use the sound enrichment. Something like below the mixing point is the level that he has to use. To get that kind of a training, he may have to attend a few sessions in the beginning. But later on, we can have a follow-up on the telephone also if it's from a far off place, or he can come to us for regular follow-ups. And we have to supervise. And when we're doing this monitoring of the management, we have to supervise, okay, to see regularly, to see whether the person is using the correct level of signal, correct type of signal and things like that, whether he's using binaurally, whether he's using it for all the time in a day and in the night also. Okay, so when this supervised management is done, then we can be sure that there are less chances of the tinnitus to relapse, or the less chances that the person will become a sufferer again. Okay, and then first 3 months we have to follow him up every month, and then later on we'll have to follow him up once in 3 months up to 12 months, and once in 6 months up to 24 months. The kind of follow-up will imply that we have to monitor them psychoacoustically. And earlier I said that psychoacoustic parameters doesn't have any correlation with the therapy outcome. That is, even though when the questionnaire says that the person has improved, that is, the annoyance has reduced, the anxiety has come down, okay, the pitch might not have changed, the loudness of the signal might not have changed. Okay, so that is the reason we have to rely more on questionnaires for monitoring than on psychoacoustical measurements. Okay, so now I've come to the last slide of this topic. So the take-home message of this webinar is, we have to, as all of us know, tinnitus is a symptom and not a disease by itself. Okay, and it is associated with other conditions. Maybe it could be medical conditions, but it is not a cause of those conditions, and it's definitely not a cause of those conditions. So these things we'll have to tell them along with other stories or parables that I've told earlier, in order to make the tinnitus, which is fearful, to convert that into a neutral stimulus. And then we should never say that there is no cure for tinnitus. Okay, they can, with the kind of counseling and habituation that we use, they can actually cope well with tinnitus. And this can be done but through counseling and sound enrichment, as I told earlier. So that's it. Thanks for listening.
Thank
And now
you,
let's
Manjula.
thank you.